In this presentation, you will be introduced to benchmarking and data mining of externally reported data. Benchmarking is a management tool that drives performance and quality improvement by allowing comparisons of performance to an established standard. There are two main kinds of benchmarking: internal and external benchmarking. Internal benchmarking is the comparison of an organization's performance over time using internal data sources. External benchmarking is the assessment of an organization's competitive position using external and internal data sources. Much of the external data is publicly available or available upon purchase. When benchmarking, both of these types are typically used. There's a general process to benchmarking. The extent to which you are able to fulfill all of these steps really depends on how much data you have access to. Regardless, the first step to benchmarking is identifying an issue. The issue should be important to your organization for evaluating performance or quality. Once you have the issue identified, you can begin to locate internal data related to that issue. Next, you can analyze that data using some of the methods we spoke about previously. This can be used using simple descriptive statistics, qualitative analyses, quantitative analyses, or exploratory analyses. After you have analyzed the internal data, try to identify external data for the purposes of comparison or benchmarking. Much of the external data is found in the public domain. I suggest looking at data.gov as a valuable resource where you can find a lot of the free publicly available data and the data that is for purchase. Next, analyze both the internal and external data using the methods we spoke about in the prior lectures. Not necessarily all of the methods, but some. And this can be used to compare your organization to other organizations. Determine whether there are performance or quality gaps between your organization and others. Regardless of if there are gaps, communicate what you found to the appropriate parties. If you did find gaps, develop a plan for moving forward. This might include establishing performance level targets and action plans for achievement. Then implement the plan and monitor progress. If necessary, recalibrate the benchmarks and then repeat the process all over again. Dashboards are very helpful for benchmarking. They are essentially a tool for presenting and visualizing data about key performance indicators. I'm going to quickly walk through a few of the dashboards that I think are very helpful. Your book provides examples to these and others if you would like further examples. Healthcare organizations are often required to report data for quality measurement. A quality measure is a mechanism that enables a user to quantify the quality of a selected aspect of care by comparing it to a criterion. For instance, a clinical performance measure is used for assessing the degree to which a provider competently and safely delivered care that was appropriate to the patient's clinical scenario and timely. A quality measure converts medical information from patient records into a rate or percentage to monitor performance across an organization. AHRQ, CMS, ONC, and other government and private entities concerned about quality request data from healthcare facilities on quality measurements. At times, this data is published in the public domain and therefore accessible by anyone. In a way, this incentivizes healthcare organizations to do well, as a lack of performance will be well publicized. Hospital Compare is an example of publicly available quality data that is available for free. I already showed you the link for the dashboard in the previous slide. The data that is available in Hospital Compare is quite large and easily accessible. AHRQ is the Agency for Healthcare Research and Quality, and they created a dashboard to compare healthcare quality across states from very weak to very strong. It uses performance measures to compare quality based on what is publicly reported. HCUP.net is an online querying tool managed by AHRQ and meant to select regional or national statistics based on claims data. The data is collected from state organizations based on a representative probability sample from the state databases and additional sample data from selected hospitals. The data is updated annually. Many researchers and practitioners utilize this data for benchmarking purposes to see how well their organization is doing against others and state and national averages. This is the only publicly available source of all payer claims data that is made available to the public. The HCUP data is made up of several unique data samples, including the National Inpatient Sample, which includes all payer inpatient data, Kids Inpatient Database, which includes pediatric inpatient data, Nationwide Emergency Department Sample, which includes all payer emergency department data, State Inpatient Surgery Database, which includes all payer ambulatory surgery data for selected states and is primarily hospital-based clinics, and State Emergency Department Databases, which includes all payer data for selected states. The quality measures made available in HCUP vary based on the type of care, settings of care, and care by clinical area. Under types of care, there are measures specifically for preventative services provided, acute care, and chronic care services. Under settings of care, there include specific databases from hospital inpatient stays, ambulatory care, and home health care. And under care by clinical area, there are measures related to chronic conditions such as cancer, diabetes, heart disease, and respiratory diseases, as well as measures for maternal and child health. Hospital Compare is a consumer-oriented website that provides information on how well hospitals provide recommended care to their patients. This information can help consumers make informed decisions about where to go for health care. The database includes information on approximately 60 measures of quality. These measures are summarized into a single star rating, making it easier to compare hospitals side by side. There is also general information about hospitals, including the name, address, telephone number, type of hospital, and other general information about the hospital. There's information on patients' experiences from HCAP surveys that measure how recently discharged patients responded to a survey about their hospital experience. The survey asked questions such as how well a hospital's doctors and nurses communicated with the patient. Measures include data on timely and effective care related to how often a hospital gives recommended treatments for certain conditions, such as heart attack, stroke, influenza, and blood clots, and how quickly recommended treatments are administered, as well as how often a hospital follows best practices to prevent surgical complications. There's information on complications related to how likely it is that patients will suffer from complications while in the hospital or after a certain inpatient surgical procedures, or how often patients in that hospital get certain serious conditions that could have been prevented if the hospital followed procedures based on best practices and scientific evidence. Data is also reported on readmissions and deaths of how each hospital's performance on the readmission and death mortality measures compared to the national rate. Finally, there includes data on payment and value of care based on the average hospital payment for care given to heart attack patients, heart failure patients, or pneumonia patients as compared to the national average payment for each condition, or providing information on payment measures and payment outcomes together allows for an assessment of a hospital's value of care, or how much is paid for a hospital's patients from time in the hospital to 30 days after leaving the hospital compared to the national average. This data is publicly released and made available for querying or download. The data elements that are available in Hospital Compare are numerous. By visiting a link on the top of the slide, you're able to get a complete list with a short description of each of these data elements. Additionally, I included a YouTube video that provides an overview regarding how Hospital Compare can be utilized for benchmarking. I'll play this video for you now.
The American Hospital Association primarily works with the hospital CEOs and the boards of trustees. So we're very much engaged with them and seeing an enormous drive on their part to make care safer. We also have what we call personal membership groups. You might think of them as the associations of the individuals who work in our hospitals, the engineers who have a critical role to play in improving safety, the nurse executives who really lead those teams of nurses who work in our hospitals, who have the most frequent contact with patients day in and day out, and who are absolutely committed to driving down the instance of hospital-acquired conditions. We're collecting data in two ways. One is that we are using the nationally reported data that appears on Hospital Compare, and the data that will soon be on Hospital Compare on central line bloodstream infections. But we've been able to see some of the preliminary results of that as hospitals share with us what they're also reporting to the federal government. Additionally, we're able to do some quick surveys of our participating hospitals to ask them specific questions as we drill down on issues of emerging concern. So we use both mechanisms to get at what's going wrong here and how can we make it better, and then to track our results and make sure that it is getting better. The federal government has an absolutely critical role in improving safety for patients. First of all, they're the ones with a lot of the data. They're the ones that can help us see what those opportunities are, and not unimportantly, help us see where results are better, which hospitals are achieving higher levels of results, because they're the ones we want to hold up and emulate. In addition, it's true that a lot of the ways in which we do what we do inside of hospitals, the ways in which we deliver care, are either governed by or at least in some respect shaped by the federal rules and regulations. How do they pay for certain services? What services do they pay for? What's in the conditions of participation that Medicare writes that lay the foundation for safety work? We are working with CMS to help them see how some of that may be changed to further patient safety. They've been an incredible partner. And then organizations like the National Institutes of Health, the Centers for Disease Control, the Agency for Healthcare Research and Quality, they churn out important scientific research that really helps us see what are the proven practices, what really should be driving our safety improvement efforts. And we use that every day in the work we do with hospitals.
Here's an example on how Hospital Compare can be used. In this example, we're doing a comparison of the percentage of outpatients having surgery who got an antibiotic at the right time. We're comparing 3 different hospitals represented by the first 3 bars to the left, followed by the percentage of Illinois, and then the percentage in the U.S. You can see that the Provident Hospital has the lowest rate, which is equal to the national rate. Also, Rush University has the highest rate, which is greater than the national rate and the Illinois average. This suggests that Rush University Medical Center is outperforming the others in this comparison and doing better than the average hospital in Illinois. Leapfrog informs healthcare decisions by putting information in your hands. They collect and report one-of-a-kind data to empower patients and purchasers to choose the right hospital. Whether you want to know about maternity care, high-risk surgeries, or steps hospitals take to prevent errors, use Leapfrog results to compare your options. Hospital participation in Leapfrog is optional, so you may not see data on all hospitals. Bridges to Excellence, BTE, is a family of programs to reward recognized physicians and other practitioners who meet certain performance measures for certain conditions, including diabetes care. The program measures the quality of care delivered in provider practices. They place a special emphasis on managing patients with chronic conditions who are at most risk of incurring potentially avoidable complications. They recognize all major chronic conditions plus office systems and a real medical home measurement scheme to promote comprehensive care delivery and strong relationships between patients and their care teams. Physicians, nurse practitioners, and physician assistants who meet annual performance benchmarks can earn a range of incentives, sometimes including substantial cash payouts. Insurers and employers fund these payouts from the savings they achieve through lower healthcare costs and increased employee productivity. HealthGrades is a U.S. company that provides information about physicians, hospitals, and healthcare providers. HealthGrades has amassed information on over 3 million U.S. healthcare providers. HealthGrades evaluates hospitals solely on risk-adjusted mortality and in-hospital complications. Its website evaluates roughly 500 million claims from federal and private reviews and data to rate and rank doctors based on complication rates at the hospitals where they practice, experience, and patient satisfaction. Its analysis is based on approximately 40 million Medicare discharges for the most recent 3-year time period available. Hospital rating reports for specific procedures and diagnoses are compiled primarily from Medicare claims data and include all hospitals that are Medicare participants. Some critics argue that claims data is not adequate enough to make determinations about the quality of care, and that conclusions should be drawn from medical records. The last thing I want to mention is the National Committee for Quality Assurance, NCQA, and the Healthcare Effectiveness Data Information Set, HEDIS. NCQA is a private, not-for-profit organization dedicated to assessing and reporting on the quality of healthcare plans, as well as improving healthcare quality. NCQA provides information that enables purchasers and consumers of managed healthcare to distinguish among plans based on quality in order to make informed purchasing decisions. Thus, this encourages plans to compete based on quality and value rather than price and provider network. HEDIS is developed and maintained by NCQA and is used by health plans to collect data about the quality of care and service they provide. HEDIS consists of a set of performance measures that evaluate how well health plans perform in several areas, including effectiveness of care, access or availability of care, use of services, cost of care, and member satisfaction with the experience of care. The link under HEDIS provides a detailed description of each of these measures. Unfortunately, the HEDIS database is not free. It costs just under $1,000 to access. I'd like to conclude by saying that benchmarking is an important process for comparing quality and effectiveness between organizations. By adopting simple analytical methods, you can develop strong conclusions about how well a hospital organization is performing. This performance may be related to the proportion of patients with diabetes that have normal hemoglobin A1C levels relative to the national average, or related to the comparison of patient satisfaction between hospitals. There are numerous ways of comparing facilities. Publicly available data is a valuable resource for these comparisons. Additionally, publicly available data can be a rich source for analysis that go beyond benchmarking. For instance, CMS data and hospital compare data to evaluate performance at critical access hospitals versus PPS hospitals in meeting the meaningful use objectives. Using these data sources, you can discover that critical access hospitals are testing for meaningful use at significantly lower rates than PPS hospitals. Because critical access hospitals are largely located in rural areas, this may be a way to contribute to a divide in care delivery between urban and rural hospitals. Similar analyses can be conducted using other data sources. It just takes a bit of creativity, curiosity, and diligence.